Now we go to a case by Dr. Swetha on neovascular glaucoma.
Thank you, Bindu ma'am, for this opportunity. So I'll be talking about a case on conquering neovascular glaucoma. The first part of the presentation will be a case. So this is a case of 68-year-old male who had type 2 diabetes mellitus and cardiovascular disease. He was on treatment. He presented with eye discomfort and mild pain in the right eye for 10 days duration. His best corrected IOP in the right both eyes was 6/6 N6, and his IOP in the right eye was 26 millimeters of mercury, left eye was 18 millimeters of mercury. So he presented with very minimal congestion and IOP of 26. So being a diabetic, I was thinking of diabetic retinopathy, and I could see a subtle neovascularization here in the pupillary area. And gonioscopy was done. It was an open angle with neovascularization of iris in all 4 angles. But the puzzle was when we saw the fundus. Fundus had both eyes to be normal, except for few microaneurysm. There was no other indication of PDR or CRVO. So then we went ahead and did the fundus fluorescein angiography. You can see that multiple tiny hypofluorescent areas were present, which indicated microaneurysms, and peripheral capillary non-perfusion areas were present in the right eye periphery. So then when you think about normal fundus and NVG, we have to do a detailed systemic workup. But here for the initial part, we did the CBC, ESR, CRP, lipid profile, coagulation panel and carotid Doppler. Then this itself came as hemoglobin to be 6.5, WBC 6200, platelet 1.4, ESR 98 and CRP was 8. His serum electrophoresis showed an M-band. Normocytic normochromic anemia was a peripheral smear. There were no blast cells. Hyperviscosity panel was normal. Carotid Doppler showed only mild stenosis, which was not accounting to this. And skeletal survey showed multiple lytic lesions in the pelvis. So finally, he was diagnosed as a case of multiple myeloma, and then we sent him for further evaluation and workup. So why I presented this case is not all the NVGs are PDR and CRVO. It can be an eye opener for a very serious systemic conditions too. So whenever you have such cases, you have to do a detailed workup of diabetological workup, then ischemic panel, hyperviscosity panel, autoimmune vasculitic problems you have to see. Even renal disease, chronic renal disease can also cause peripheral retinal ischemia. Now the second part of my topic about an NVG, it's not a hopeless disease. Once you see NVG, we feel that eye is lost. It is not like that. It is a stage disease. Once you understand the stage, these stages can be conquered. So we have pre-rubeotic, rubeotic, open angle and closed angle stages. The treatment, we have to do a primary treatment and a secondary treatment. Primary is to find and treat the cause and treat the IOP. Secondary, never forget about anti-inflammatories. Steroids need to be given, cycloplegics needs to be given because patient will have pain, and any cataract that also need to be addressed. So treatment, basically it involves regression, ablation and treatment of the refractory IOP. So regression is mainly anti-VEGF. We have lots of anti-VEGF which we have now in market. Then the second stage is the ablation, that is peripheral panretinal photocoagulation. And if the IOP is refractory, we can go ahead and do the tube surgery or trabeculectomy. Generally, whenever we see NVG, we say always tubes, but no. If the eye is having less of inflammation, even a good trap can survive. It can control the IOP. If the pain is, if the IOP is not controlled, then you can go ahead and do the cyclodestructive procedure. Once you have a rubeotic stage, this is a stage where we can save vision early. So it's always important, you have all the retina cases, needs to be seen by a glaucoma specialist, do a gonioscopy, PDR, CRVO. You can never miss this stage, because once it goes to the next stage, everything changes. So once you have rubeotic, you go ahead and give the anti-VEGF. You can do an early PRP. Always treat the underlying cause. Almost 90% of eyes can be saved if in this window. And open angle stage, when the IOP is raised, you can give an anti-VEGF and PRP urgent, and then control the topical, IOP with topical and systemic AGM if required, and closed angle control. And closed angle stage, here the IOP will be more, and you need to give the anti-VEGF to quieten the eye, if the eye, and give the maximum anti-glaucoma medication. If it is not controlled, go and do the surgery. And end stage and low vision, don't abandon the eye. If there is potential, you can cyclophotocoagulation. If not, you go with the cyclophotocoagulation. Always treat symptomatically. If there is no vision in that eye, you don't have to go and treat these patients very aggressively. No vision, just pain, just treat it with anti-inflammatory and atropine. But if the patient is still having high IOP and pain, then go and do CPC. But if the patient is not having pain, no need of putting him on too many medications. You can just treat symptomatically. So timing is everything. Anti-VEGF is the first weapon. PRP is a backbone, and surgery is often inevitable. Thank you.
I think picking up an NBI and
Coming to the diagnosis.
Actually, that NVI was not seen initially. I did a gonioscopy, I saw the NVA, then only I saw the NVA. I mean, NVA, then only I saw the NVA. It was not seen in the slit lamp examination.
still you thought
You for all my I do gonio for all my primary cases. No, sir, sometimes even if the slit lamp is good, if we do not focus on that area, we will miss it.